You've got a cough, the usual runny nose you have here and there. You're feeling fatigued, sure, but you think it's just another cold. I'll shake it off. But then you get a fever of 38 degrees. You're shivering under 3 blankets, and the cough? It's just not an annoying tickle. It hurts. It's deep. You're coughing up a bunch of yellow phlegm. You can barely take a breath. Now you know you need to go to the doctor, and in your head, there's only one solution: antibiotics. But what if the doctor listens to your chest and says, no, I think it's just a virus? What if the cough is just a common cold, a viral issue? In this episode, we're going to cut through the confusion. We'll show you how to spot the few dangerous signs that tell a cold is actually pneumonia, and why sometimes the safest, smartest answer from your doctor is appropriately, no, not this time. You don't need antibiotics.
The views and opinions expressed in this podcast are those of the hosts and guests, do not reflect the official policies or positions of any affiliated institutions or organizations. This podcast is for informational, educational, and entertainment purposes only, and it is not intended to provide medical advice, diagnosis, or treatment. Listeners should consult their own health professionals for any medical concerns.
I'm James Jung, a general surgeon.
I'm Brodie Nolan. I'm an emergency doctor.
And I'm Josh Levitz. I'm an internal medicine physician, and this is not another medical podcast. Podcast.
What a beautiful day with beautiful people to produce a podcast episode.
Thanks, buddy.
Yeah.
I love that energy.
It was a nice fall day today.
Yeah.
Although we had snow.
Oh, that's not fall.
How much of that are you getting down there?
Yeah, I mean, that's not, I don't know what you're talking about. That's not fall.
Yeah.
That's like bad weather.
It made raking up leaves really difficult.
Oh, wet sludge leaves.
Oh, you couldn't do it. Yeah, Canada's the best. I love Canada.
Working the triceps.
Oh yeah.
I could even see through your black shirt.
Thank you.
Looking huge. You've been lifting leaves.
Guys, hold on. There's an elephant in the room, and we got to get this out here because we don't know what happened. Brodie, you apparently have a new living space, sometimes known as a house.
Yes. Yeah.
What happened, Brodie?
It's been a
bought new
crazy
house.
Couple of weeks. Yeah. I will say, trying to sell a house.
Listeners, we have not heard this yet, so we're all just learning for the first time together.
Yeah. If anyone's listening, you will know that right now is a terrible time to sell a house. But we've been trying. So over the last 3 weeks, we've been having our house open for showings and stuff, which is awful when you have awful anytime, but then especially with two young kids, because it's 2 hours a day of cleaning and putting stuff away and trying to pretend like we're not living here when we're clearly living here. But our neighbors, literally 10 houses down from us, were looking to sell their house. It's fully renovated, and
which you really loved, right?
We loved it. It's beautiful. She's an amazing designer. Big shout out.
Give her company a shout out.
Yeah, Natari Designs. It's great. She's
awesome. What is it?
And very lovely. Natari Designs.
Natari Design. I saw those pictures.
Yeah.
I was very impressed.
Yeah,
it's a beautiful house.
Yeah.
Does the house come with all the furniture?
It was initially, but then we negotiated some other stuff. So no, unfortunately, we still have to. But that's okay. Yeah,
so
reasonable.
At some point, you have to buy the furniture.
Yeah, at some point we need to buy some other furniture. Yeah, but don't worry, listeners. The dinosaur is still going to come with me. So
yeah, excellent, excellent news.
But in typical fashion of nothing waits for Emerge though. So anyways, we've been on the market for a while. Monday night I'm in for a shift, and it's James. This is the day that we're getting not great weather. So luckily, the Emerge is relatively not too busy. Mm-hmm. I get a note or a message from our realtor saying, "Hey, you have an offer." Okay, well, I'm on shift. This isn't great. I'll have to review this later. And she's like, "No, it expires tonight." I'm like, well, okay, I guess I'm gonna have to deal with this now. At the same time, someone had presented to the hospital after having something placed up their butt, and they needed it to be sedated.
Not an infrequent encounter.
Not an infrequent thing. Yeah. And I'm sure we'll do an episode at some point. But the butt vacuumed.
Guys,
it does.
Hold on. I just got to point out how calm we all are, because it'd be like, yes, we've all seen that. Next. It's so
Uh,
normal.
Yeah. And so then I was, very carefully attending to the
Yeah.
patient, but at the same
Yeah.
time texting with my realtor,
Mhm.
helping to facilitate the removal of said
Mhm.
thing from
Yes.
said butt. So it was a very, classic
Yeah.
Typical
buying experience,
Yeah. Yeah. What one would expect a foreign body in the rectum to be involved in
Yes.
any, sales tactic.
Yeah. I mean,
And the
classic, typical Tuesday,
Yeah. Typical
And the
Tuesday
best
real estate.
the best part is, assuming this is your forever home, that's your forever story.
Yeah.
It's amazing.
So, anyways, yeah, very excited. We were briefly homeless for like a day. Well, we had sold our house and not yet bought the other one, but it's all good. We're moving on,
you'll
moving
have
on, and
a-
moving in. Very exciting.
That's awesome, man.
Just
Congrats.
so like literally 10 houses down the road, right? Like same road.
Like, we will obviously buy movers, but we could. It's downhill slightly, so we could like get a trolley and like
a
kick our stuff
trolley.
down.
Yeah.
Mm.
Yeah.
Yeah.
Just
Yeah.
like get like some skateboards and
Oh, that'd be a lot of skateboards.
James,
That's a good
how
idea.
How are your neighborhood kids? Think they'd? You said they're hard workers.
they're entrepreneurial.
Think they'd make the flight?
Yeah, I think if you
All
fly
right.
them over. They're minors though, so I don't know if they can fly by themselves.
yeah.
Mm.
That gets complicated. I feel like.
Yeah, it gets complicated. And also like, cross border,
Yeah.
labor law issues
Tariffs.
and things like that.
Yeah.
Can't afford them with the tariffs.
Yeah, but I'll drop them a line. Let's see what they say.
So
Let me know.
So I know, guys, I know this isn't about me, but I got a little worried because Brodie and I, listeners, we've always lived within close proximity to each other. So like we lived in the same building in med school. We lived like a 10-minute walk in residency.
Separation anxiety is real.
Yeah, it could, no, some people call it codependence. and so when he said it was moving, I was like, uh-oh, where's he going?
Mhm.
Because I can't go farther than this, but it's 10 houses down.
Yeah.
I think I can handle it.
Arguably, depending on the way we walk, it's about 45 seconds closer to you. So
Win
you're
for
a lot
Josh.
we'll take it.
Josh's day just got better. The triceps just got bigger.
They got bigger. That's how it works. Exercise.
Speaking of something that spreads, no, I'm kidding. I was like, what segue can I do?
James, let's start that segue again, shall we?
I don't really have a segue anymore. I think I really pooped that.
I think we acknowledge the attempt by James and
Yeah.
thank him for his effort.
I think what James was trying to say is, speaking of things that spread, like a pneumonia can spread.
Especially within a household or
Ew.
between close neighbors.
Or how about this?
Oh no.
You've acquired a house within your community.
You're using
And-
pneumonia. It's words.
Community acquired pneumonia is a thing, and we did it.
There we
Okay.
go. Nice. Okay. All right. Back to James.
Why is this so hard?
I think I need to take some lessons on segues.
We all do.
Nope.
I would say that, pneumonia is such a common reason for why somebody would present to the hospital and get admitted. I think this is really you guys that see a lot of this. So, I'd love to ask Josh, you see them as inpatients, and Brodie, you see these patients coming into the hospital. Tell us a little bit more about the significance of this disease and why this is something that we want to talk about today.
For sure. So I chose this for a few reasons. Number one, most people have heard of pneumonia. Whether you actually know what it is or not, we'll find out, because some people, I think they know what it is, but might be different. Number two, I see this every day, multiple times a day. And even people who don't come in with pneumonia can develop pneumonia in hospital. And Brodie, I'm guessing this is one of your top diagnoses that you have in the Emerge as well. But yeah,
Especially this time of year.
So, especially this time of year, and we're getting into kind of viral season, and pneumonia's come along with that. So just very, very relevant, and it's a really cool thing to talk about. Maybe kind of set some myths aside, explain a little more, and get some good information out there. If you'll have me.
Wait, do we have a choice? Can we not have you? James, can we just have the two of us? I'm just kidding, buddy. You wouldn't want it any other way.
You called my bluff.
Unless Jeff's available. Get that guy back.
So let's talk a bit about how we define it. Pneumonia sounds like not really an English word. So tell me what it is in English.
James, I think this is excellent because I quite frequently we'll have people using terms like pneumonia and the flu or a cold quite interchangeably. And I do think that it's a really key point of this, of just like, what is the difference? Josh, when you're talking about pneumonia, what is a pneumonia and how is that different from a cold, maybe, for example, or the flu? Can you maybe break it down a bit?
And I think that's really important because people just walk around saying they have pneumonia where you probably don't, or you might not. So pneumonia, just by definition, pneumonia is an infection in the deep lungs, like pretty much below the kind of the speaking box, the larynx. So any deeper lung infection is considered a pneumonia. And that's really important because pneumonias often require different treatments than your run-of-the-mill cold or your run-of-the-mill flu. Although those things can cause pneumonia as well. We'll get into that a little bit. So it's really important that we don't just use it willy-nilly. Also, I wanted to use willy-nilly during this podcast. Checkbox. Because it really does, it means something different.
So that's good. And, the way I think of the anatomy of the airway is kind of like an inverse tree. So, the tree has big trunk at the bottom, and then it kind of branches out eventually. So they're divided into two branches, and then, goes into several different branches. But think of it kind of flipped. So you start with, on top of it, trachea, which is the big trunk, and then become two branches, left and right, and then they go into several different branches. Pneumonia is really lower, respiratory tract infections. So these are kind of at the branches level of the tree. So I think that's one way to kind of think about that.
And for listeners, one of the coolest things, if you look up, just Google lung X-ray swallowing contrast or lung X-ray aspirating contrast, you are going to see these cool pictures where someone swallowed this opaque fluid into the lung tree, and you can actually see all the alveoli and all the airways. It's super cool.
Super cool to see, but not cool for the patient.
Not to do. Don't do this.
Don't do it.
Google it. Don't do this. Google it.
Learn from that mistake.
It's equally beautiful when they pull out those giant clots of someone's lung as well, and again takes the form of like the small airways, like belongs in an art show for sure. But unfortunate for the patient.
Yeah, it is. And what pneumonia is like truly the deep infection. It's when the alveoli, the areas of the lungs that kind of exchange oxygen and carbon dioxide, it's when they get filled with infection, with essentially pus, and causes all the symptoms associated with that.
So Josh, if a pneumonia then is an infection within the deeper lungs, then how do you differentiate that from a cold?
Yeah, so just anatomy-wise, symptoms-wise is different, and that's what we will definitely talk about. So a cold, a viral, what we usually call an upper respiratory tract infection, or a URTI, if you want to sound really cool, is just that. It's kind of in the nose and the throat and higher up. And the majority of those are viruses, like a cold is normally a virus, and they don't need antibiotics and things like that. So it's really an anatomical differentiation, and the symptoms of a pneumonia in general are much more severe than the symptoms of just an upper respiratory tract infection. In general, there's no absolutes here.
The URTI just came to me. Does anyone call it Ernie?
My God, James, I literally in my mind was like, don't say my Ernie hurdy. That's all I could think about. And this is not planned. We are clearly linked.
So remember when you guys offered to not have me on?
Yeah. My Ernie hurdy for you.
I'm reconsidering.
Josh is going to go solo and be successful, and James and I are just going to be living in basements.
Good times.
Oh, man.
Good times.
So now tell us a bit about causes. So you said infection. So there's some pathogen involved, right? So I think there are two big pathogens that could be involved in causing pneumonia. Tell us a bit about, we're going to talk about virus and bacteria, how they differ and how their presentations differ.
Yeah, for sure. And again, the episodes on pneumonia, we're going to talk a lot about the upper respiratory tract infections because you really can't talk about one without talking about the other. So yeah, two major types, and there are some other ones which I'll just briefly touch on. So viral and bacterial. And just because a cold is viral doesn't mean a virus can't cause pneumonia. So again, a virus can cause a lower infection. And we're a few years out, but COVID, lots and lots and lots and lots, and I could keep going, COVID pneumonia. That was one of the biggest things there. So the majority of pneumonia we see, though, at least, again, I'm in Southern Ontario, are bacterial. And the majority of the upper respiratory tract infections you see are viral. Again, not black and white, but those are the general differentiations. And I don't know, do you guys want to get into how we differentiate them now, or anything else you want to say before that?
Well, tell us about like common kind of treatment misconception, on, even upper respiratory tract infection, even though it's viral, some people may ask for antibiotics, right? So tell us a bit about, how this treatment differs based on whether it's bacterial or virus. But of course, not always you can get, the pathogens right away.
James, we have a script and you're going off of it. And my mind can't handle this at 8:30 at night, okay? We were supposed to go in a certain direction. And now we can talk about it. I mean, we got to get into this because this is the biggest thing. And if we don't talk about anything else in this episode, it's everyone knows you don't need antibiotics for every infection. And this is a classic one where you'll walk into your family doctor's office or you'll walk into the emerge, you'll feel a cough, you'll have a runny nose, you may have a fever, and you'll say, I need antibiotics. And the doctor is going to say, no, you don't, because they think this is a virus. And you should not have antibiotics for viruses. That's not a thing. Now, sometimes it is hard to differentiate bacterial pneumonia and viral pneumonia, and that's fair. But most of the time, this is going to sound awful. Most of the time when you think you need antibiotics, you probably don't.
Probably don't.
Yeah.
But it's so hard too, because there's also a level sometimes of expectation, especially, right now of waiting. And then sometimes you're going to, I'm sure we'll talk this down, but again, for differentiating between the two can be challenging, especially if you don't have access to things like an x-ray or maybe swabs or things like that come around quickly for results. So it can be really hard. But yeah, to your point, antibiotics treat bacteria. Antibiotics do not treat viruses. So if you are sick with a virus, antibiotics will not do you any better. And then, of course, you have all of these people that are like, well, I got antibiotics and then I got better. Like my runny nose went away. And, well, you were going to get better on your own anyways.
Yeah.
You just exposed to the risk of antibiotics, which, again, I'm sure we can talk about and stuff down there. So.
Yeah. I think this is just a kind of preview of like more in-depth discussion about the treatment. But I think where I was getting at was, virus, bacteria are different. How they present is a little different. Virus, a little bit, the line between is pretty blur sometimes, but, virus is more insidious, like it takes a little bit longer, gradual onset. Bacteria is more like right away, you get high fever, and the onset tends to be more acute. So those are kind of the symptoms that are different by pathogens. So now tell us about symptoms. Maybe start with you, Brodie, how they present. What symptoms would you think that these, this patient likely has pneumonia versus early or upper respiratory tract infection?
I think everything's a bit of a spectrum, if you will, right? So most of people are going to feel some degree of just blah. Maybe there's fevers or there's chills. They might have like myalgias, like those kind of like muscle aches that they have. And then, often both will have a cough as well. And sometimes whether it's viral or bacterial, will also be, bringing up some phlegm or sputum or mucus with that cough as well. And sometimes you can also get pain in your chest because things are inflamed. There's some mucus in there. So it tends to be associated with maybe some chest pain. Again, often while you're coughing, or sometimes if you're taking a deep breath, there can be pain there too. And I'd say those are all common between upper respiratory tract infections and pneumonia. Now, what I tend to see then is pneumonia tend to present with more severe illnesses. So they tend to have a higher temperature or, higher fever. They might have a little bit of an elevated respiratory rate because they're breathing just a little bit more because, again, that lung exchange, that oxygen exchange in the bottom of the airways is impaired because they're fighting against stuff. So sometimes their oxygen levels might be a little bit lower. And then usually the amount of that phlegm is thicker, more purulent. Those are the things that I think would lean me more towards it being a pneumonia. And then on the flip side, usually with an upper respiratory tract symptoms, people have other symptoms that make me think it's less likely to be a bacterial pneumonia. So if you're coming in and you're like, my throat is also sore, my nose is runny, my ears are full, that to me says you probably have more of an upper respiratory tract infection. because it doesn't sound like it's really isolated to the lungs. So those are kind of the tip-offs that often the more symptoms you have outside of the chest, for me, the less likely this is as an actual bacterial pneumonia. Whereas if you are, fever, hurts when you take a deep breath in, coughing up a lot of phlegm, and you don't have sore throat, runny nose, fullness in your, ears and sinus and stuff, that makes me think it's more likely to be a bacterial pneumonia.
And what I often talk about with patients are the spectrums. So there are clear URTIs. You come in with a runny nose, watery eyes, maybe a little bit of a cough. Yeah, we're talking viral. You come into the emerge, you can't breathe, you're coughing, you need oxygen, you're ending up in the ICU. That's pneumonia till proven otherwise. So those are the easy ones. It's the things in between that can really blur. And that's where you need some of the other tests we'll get into as well.
Yeah.
So well said, Brodie. Well said.
Yeah.
Thank you.
Why don't we get into that? So how do you guys, differentiate, those two? How do you diagnose pneumonia?
Yeah, and just before we get into it, one thing I want to dispel right now is there's an old thinking that fever equals pneumonia, no fever equals virus or upper respiratory tract infection, and that is absolutely not true. I think going through COVID, everybody can see that viruses can cause fevers.
And very high fevers too, right? Like a lot of people with COVID had temperatures of 40, right? Like it was very high fevers, still viral. Yeah.
Yeah. So I just want to dispel that right away.
40 is like the 101 in Fahrenheit.
Oh, yes, right.
Thank you.
Yeah. Doesn't AI auto convert this when you're listening, depending where you are? Although, great idea.
Actually, 105 Fahrenheit.
Is it really?
Yeah, 105.
Wow.
Very high.
Pretty high. 40 is very high fever, yeah.
And that's the thing. And even that, how high your fever is doesn't differentiate between a bacteria and a virus, or sometimes between an upper and a lower respiratory tract infection. So throwing that out there.
I think that's very important. Fever, fever just, it's not specific to anything. Fever just inflammatory response, right? So I think that's very important. So Brodie, when somebody like this comes to emergency room, maybe, not clear picture, what's your approach to diagnosing?
Yeah. So, obviously I'll look at things like their vital signs and their temperature, their oxygen levels, and if they're having trouble breathing. But really, I think for most of us, the go-to test is a chest x-ray. Because if you're getting to the point that you have bacteria within the lungs causing that inflammation, you're going to start to see that on an x-ray. And it's kind of interesting, the x-rays, as it shoots the x-ray beams through your lungs, are mostly filled with air. So it doesn't pick up it doesn't absorb a lot of that x-ray as it goes through. So what we're looking for when we're looking for pneumonia on a chest x-ray is we're looking for what we'd say consolidation. So is there less x-ray beams actually getting transmitted through to the other side? And so you'd see if there's kind of like white spots on the lung, if you will, that would kind of show us that you don't have those x-rays penetrating as much. And I think that's really kind of the go-to diagnosis for the most part for the emergency department and the walk-in clinics. There are some really cool things that are coming out now with point of care testing for viruses. So in the same way that we were doing, swabs for COVID and sending those off to the lab, there's now some devices and tests that are doing like a 15-minute turnaround time where it'll look for common viral causes like influenza or the flu or RSV, which is a common one we see as well. And then you kind of get a nice like yes or no for some of these big viruses right off the bat, which again might be able to save people getting exposed to risk of antibiotics, and if that's the case. I don't know, Josh, if there's anything else that you see with that.
No, and I'll back up even before the emerge. This is where GPs, the family doctors, have a harder time because they don't have access to X-ray the way we do in hospital, or as quickly for the most part. Again, talking where we live. So the GPs have to diagnose it based on the history, what you talk to the patient about, the physical exam, what we hear. And maybe some blood work they can get back quickly. You look for like how high your infection fighting cells, your white blood cells are. So they just have to make their best decision based on symptoms, and they'll go on severity for the most part. And so it's really tough. In the hospital, we're lucky.
Right. Could you guys kind of, talk a bit about that last art, which is physical examination, auscultation, if you will. Now we don't use stethoscope anymore. We used to have like some stethoscope ceremonies, like kind of like a white coat ceremony. What like, to the best extent that you can, like what kind of sound do you expect from normal lung fields versus lung fields that have consolidations or these infection but infectious area?
Really tough question, James. The physical exam is very important, and I got to be super careful how I say this, but it is not a great way to diagnose things because pneumonias can have these weird sound. We call them rhonchi. Essentially, you're hearing that thing and how it affects transmitting sound in the lungs. So it's just a different sound we hear, but not hearing that by no means rules out a pneumonia.
Right.
So we use a stethoscope. If you hear something, it may be helpful. Yeah. But there's also other things. If people have asthma, if people have COPD, like other lung disease, if they have other lung issues, you're going to hear something whether they have pneumonia or not, and you can't tell the difference. So physical exam is really important. It's so hard. Some of us these days think physical exam is disappearing. Some of us believe it is still as important as ever. Depends where you fall on that spectrum. How's that for treading a line?
No,
Brodie? Pretty decent.
I think that was really good.
I still wear my stethoscope on shift, and it's mostly just to listen for lung things because it's like, okay, you can hear a wheeze, which will sound different than those kind of rhonchi or crackles or some other things. But it's really tough, and it depends too on like how hard the person's breathing. If they're taking really quiet, shallow breaths, you're not going to hear anything. If they're taking really big, deep breaths, all of it's going to sound kind of weird and awful. So it's interesting. Like you can kind of definitely
and Brodie,
user dependent.
Brodie, you wear the stethoscope because it looks cool. And I know when you go out for your fast food restaurant at 3 a.m., you're wearing that stethoscope in line. I know what you do.
Yeah. I only ask because I don't use stethoscope anymore.
James, do you even know where is it? Do you have one?
I still have one, but Leo, my 3-year-old, plays with it.
Yes. That's actually
that's a good use.
Yeah, so you don't listen to the belly of any of your patients anymore.
And that is the worst physical exam test, I think. Oh, I got to be careful with that bowel sounds. But just to add a little bit for listeners,
we're going to get in trouble here, guys.
No, I think it's a reality, right?
It's honest talk.
Brodie talked about X-ray. Easy way to think about it is air is black and dense stuff like bone is white. So if you see whitish consolidation, like kind of whitish scratches or kind of like a circle-ish area in lung fields that should be black, those are kind of the consolidations they were talking about that may be concerning for something like infectious disease. Okay.
Sure. So one more thing I should mention is if you're not getting better or there's some uncertainty, you may end up getting a CT scan, like a super X-ray, just to really get a better view of those lungs and the alveoli and see if there's something else going on. Not the norm, but you may end up going that route.
Yeah. Or what I also find happens is they come in, they're so sick with something else, right? Let's say they're just like confused, not making sense. The oxygen levels are low. They need to be sedated and get a breathing tube and stuff. And then you end up CTing them for something else and then find some pneumonia or inflammation there too. Yeah. It's a good point.
Good point. All right. So let's talk about how to treat. I think this is like really, we've got into it a little bit early, but let's talk about, well, first of all, general kind of prevention, first of all, like obviously the most important is preventing you from getting this sick. And then we'll talk about treatment. So prevention first.
Yeah, so prevention is the best treatment in our eyes. Very, very, very simple stuff. Wash your hands. Please, everybody, just wash your hands with soap.
Can you tell my daughters?
I know. My daughter always runs out of the washroom. Nessa, did you use soap? Oh, I always forget, Dad. I don't know why I always forget. And then she goes back and she doesn't do it. And I'm still baffled this day and age in the hospital. I watch people walk out of the washroom without washing their hands, and like on the regular, not just once in a while, every day. I'm just like, just wash your hands. Come on. Number 2, from a prevention perspective, it's hard, but staying away from people who are coughing up a lung, and you yourself, if you are coughing up a lung, trying to stay away from people. We're in a world where masking has become a bit more normal, if not polarized. So your choice whether you mask up or not. But one of our good friends, and I can give her a shout out, Julie Wright, Dr. Wright, who's an infectious disease doctor. Yeah. She told me it feels great to keep yourself healthy, but it could feel better to keep other people healthy. And I think that's really, really important.
That's very classic, Julie.
Such a Julie thing to say, and we love her for that. Yes.
Should have her on this show.
I try.
Yeah.
I'm trying. I'm really trying. Listeners, Dr. Wright we went to med school together. She's like the best. And then I think the last.
Now I feel I'm a bit offended.
Well, she is. She's better than us. You guys know this.
I mean,
No
that's why I
question.
didn't say anything.
Just me.
But I think, one thing that COVID has taught us is like, washing hands. Like we all know how to wash hands. I mean, hopefully. I mean, evidently
My daughter.
not. And, if you're sick, avoiding social contact, right? I mean, don't spread
Yeah.
the disease, So
Yeah,
I think
just
those
stay
are
home.
really
Yeah.
important things.
Yep. And then the last thing, which again should not be controversial, but it is this day and age, and that's okay, are vaccines. So there are pretty good pneumonia vaccines that guidelines are different everywhere. And because people are going to listen from everywhere, I'm not going to say guidelines, but in general, if you are very, very young or older, 65 or so, depending where you are, it's recommended you get the pneumonia vaccine.
Yeah.
The important thing to know about the vaccine is it only covers certain bacteria, not all pneumonia causing bacteria, not viruses that cause pneumonia. So it doesn't protect you 100%, but it reduces the risk of getting it a good amount.
Yeah. So these are the pneumococcal vaccines, right?
You got it.
That, protect you against Streptococcus pneumoniae. They're known as Prevnar or Pneumovax, depending on where you get them. So, ask your doctor, talk to them about it. Certainly there's good, evidence to suggest that this is helpful.
There is.
If you're over a certain age as well.
Completely. And we know now there are COVID vaccines, there are flu vaccines, there are RSV vaccines. So those are all viruses that can cause pneumonia.
Yeah.
So you should be talking to your doctor about getting those. I don't know about you guys. As a healthcare worker, I get flu and COVID every year.
Yeah.
Yeah. So those are the most important on the prevention side of things. Wash hands, stay away from people who are sick, and vaccines. So that's the easier said than done world.
Yeah.
That's true. And then you hit with real life.
Yeah. And then you're here with real life. Yeah.
Yeah.
And you have kids
So-
and you're getting
Yeah,
sick.
Screaming
Yeah.
kids. Yeah, exactly.
Yeah. All those things.
All right. So, Brodie, I know we're going to talk about the meat of the treatment, like antibiotics and all this stuff. Tell me if somebody comes in with respiratory, symptoms that are severe, what's your kind of approach to triaging these patients with respiratory distress? And, just briefly, like how would you think through this kind of patients? Because that airway becomes very important.
Yeah, totally. And again, for me, like vital signs are vitals. The first thing we'll look at is, again, what's their oxygen saturations, what's their respiratory rates, how hard are they breathing, how fast are they breathing? And if they look like they're in distress, then we're going to attend to them as soon as we can. And often then give them additional oxygen to help with their oxygen levels. They might need a breathing mask to help that. And in some cases, and especially with pneumonia, it's not the type of lung disease that gets well with things like more of like a non-invasive mask, like a BiPAP or a CPAP. So, we can try some humidified oxygen. And then if that doesn't work, then often we do have to go to a breathing tube sometimes for these patients. But that's usually kind of the initial assessment, right? Then we're doing all the diagnostic tests that we're talked about, getting x-rays, getting blood work, obviously having a listening to the lungs and going for there.
Yeah. And I think, parents who have little kids should get worried if you see your child breathing in kind of the tripod position, we call it. So where they're sitting down and then they have one of their arms down and then they're like taking deep breath in and out. Those are kind of signs that they're using a lot of the accessory muscles and really in respiratory distress. So when you see, your family members in that kind of situations, it's very important to bring them immediately to emergent care. Very important to do so.
And I'd also say, honestly, probably best for doing like a 911 call or whatever the number would be because again, especially if your oxygen levels are low, paramedics, EMTs can give you extra oxygen, right? Can start that treatment on your way to the hospital as opposed to waiting until you're there.
Not the time to call Uber and or drive yourself.
Yeah. Don't look for your Lyft discount.
So Josh, I think this is the real meat of our discussion in terms of treatment. So you see them, Brodie called you, this patient's sick. What do you do?
James, I noticed you're using the word meat a lot. Are you hungry? Did you have dinner?
No, I had a big steak today, so I'm still
Okay,
reminiscing.
that's just on your mind.
Fresh in the mind.
Okay, cool. I like it. I like it. Okay, so antibiotics. Number one, we already said it, but we'll say it again. Many people who think they have pneumonia don't need antibiotics. And many reasons we don't use antibiotics if you don't need them. And I think it's really important we put them out here. So we talk about resistance a lot. Bacteria love to grow resistant to antibiotics. And there's already so many of them. So if we give antibiotics when it's not truly a bacteria, all the quote unquote good bacteria in your body can start to build up immunity to that antibiotic. And if one of those bacteria cause an infection later and antibiotics don't work against them, then it's a more difficult issue to treat. So I know we talk about that. I know patients hear that all the time. It is very real. And there's even causes of pneumonia now, like streptococcus, which is a very common cause of pneumonia, that are resistant to medications we were using 10, 15 years ago. So these things are real. So we don't just give out antibiotics for the sake of it. Number two, antibiotics do have side effects. And although most people don't have the side effects, or at least serious side effects, some people do. And it's hard to tell who's going to have it. So again, we don't want to give you antibiotics if you don't need them. So our goal as physicians is to figure out if you truly need the antibiotics. Again, if you're in a GP's office, maybe a bit harder because they don't have the x-ray up front and stuff like that. But if they think you're sick enough, they will give you antibiotics for it. Once you hit the emerge, if you've gotten to me, if you've gotten through the emerge doc, they've referred to me, you're on antibiotics. And there's many different types we use and we don't have to get into those. So that's really it. And then on top of that, like Brodie said, we have the supportive care of fluids if you're dehydrated because infections dehydrate you, oxygen if your lungs are filled with pus because you can't breathe. And then we have many other supportive cares. So all that to say, antibiotics are great if you need them, not great if you don't. And then we also live in a world where there are viral medications, antiviral medications. We have some for COVID, we have some for flu for specific viruses, and then there's other more rare viruses we have treatments for. So that is the big 100,000-foot view of antibiotics.
Just to give an example of that, Josh, the kind of primary care, emerge, walk-in clinic kind of setting, 20 years ago, there's commonly that you'd walk in, you'd get upper respiratory tract symptoms, and you'd be given like a Z-Pack or a Z-Pack, right? And it was like a standard 5-day course of azithromycin, and everyone got it. And then over the course of like 5 or 10 years, there was just so much resistance that antibiotic essentially became useless. Right. And even now, like it's the one that we really can't lean on because there's still all of this resistance to it because we relied too heavily on it. So totally to your point, like antibiotic resistance is very real. The way that I try to balance this with patients sometimes, especially if I'm quite confident that it's a viral infection, because again, I can be wrong, but I'm quite confident it's a viral infection and, we're discussing about antibiotics and talking about the risk. Often I'll be quite frank and be like, well, do you want diarrhea with your cough? If you do, I'll give you antibiotics, right? But again, you're just going to get exposed to side effects without any benefit, and you just need time. I think the hard thing is patients feel shitty, right? Like they feel awful. They don't want to feel this way. That's why they're going to the hospital. That's why they're going to see their family doctor, and they want something to get better. And unfortunately, for a lot of viral upper respiratory tract symptoms or upper respiratory tract infections, there isn't a magical pill. If there was, it would be a multi-billion-dollar drug. But there isn't. You need time. Sure, you can try cough syrup. It's probably not going to do much, but it's just like you just need to kind of sit and ride it out for a week, right? And I think, but I feel for people. They feel shitty, but you don't want diarrhea on top of feeling shitty if you don't need to.
So I think it's helpful, as I'm listening to you guys talk about this, for the listeners to kind of think about the two types of presentations. One is kind of what Brodie is saying, and maybe they don't go to Josh. These are patients who are not have high fever. They're not in respiratory distress. They're ambulating, they're walking, they could go home, but there isn't perfect tests to determine whether it's virus or pneumonia. Your chest x-ray was equivocal, wasn't sure. And in that way, I think Brodie's approach of, okay, we think it could be virus, not sure, maybe we'll give you some antibiotics to go home with, but, write it out. I think that's one type of patients. Whereas the other type of patients that sees Josh, they're sick, elderly, on supplemental oxygen, high fever, definitely spots in the x-rays. These are patients who are getting empiric treatment, right? So we don't have all the pathogens yet, so they're going to get broad spectrum IV antibiotics, supplemental oxygen supportive care, admissions to the hospital. So, for those patients, when we don't have the luxury of waiting to see whether this becomes a virus or a bacteria. I think it's very important for listeners to, kind of think of it in two different approaches.
Yep.
Like if you're sick, I think you should be getting antibiotics to start.
Yeah. James, really, really awesome point. And I think what you're saying is if you are sicker, we don't have the luxury of trying to know if we're right or wrong. We have to treat you and back off later, as opposed to if you're well, not treating you with antibiotics and adding them on later if we're wrong, which is less common, is the way to go. So you're absolutely right there. And I think
You just summarized emergency medicine.
in general.
That was 5 years of training
I
right
could
there,
do that.
team.
I could do that job.
It was amazing. I love that. And two things that I just want to throw out here, just so it's on record. Number one, the older you are, the more medical issues you have, the less classic symptoms you may show. So you can have pneumonia without actually looking that sick. Sometimes you don't mount a fever like you used to when you're younger. So we can't always depend on symptoms. So sometimes we will treat you up front if you kind of look sick in other ways. Number two, completely unrelated, if we think this is a viral pneumonia, bacterial pneumonia like to jump on top of viral pneumonias. So we call them secondary infections. So if you have a virus for multiple reasons, bacteria can flourish a bit more. So just because we think it might be viral, we might also say, oh, you know what? There might be a bacterial here, so we're going to treat with antibiotics. I just wanted to throw those two things out there. They don't really fit in everything, but important to put out.
Yeah, very important. You can start having upper respiratory tract infection, viral infection, and then get superimposed with bacterial lower respiratory tract infection. I think, in fact, that's what happened a lot during COVID era as well. So I think this is why it's so important that, these things could happen simultaneously. We can't really tease it apart like easily. It's not black and white.
James, you are just a good host. I'm just going to put it out there. Like,
it's because I'm not an expert.
No, but it's amazing. Like, I get lost in what we know.
Right. I think that every time we rotate around, what I see is I sound smarter when I'm not the expert. Because we get so tunnel vision, right?
We should explore that.
Yeah, I think it's
We're now transitioning into a therapist.
We should get a therapist on here for us. That'd be incredible.
This is at least the second time we've said that for the record.
Is it really? Oh boy.
Yeah.
Oh, I think we've been saying that for the last 20 years, but
Oh God.
Really?
Yeah. Hey guys, do you hear that? It's the myth busting time.
Hold on.
Josh, do you have things to say?
Yeah. I do. Way to derail us, Josh. I want to point out, so let's say you get all these treatments, antibiotics, maybe not antibiotics. You're at home, you're not getting better. Let's say the cough is getting worse or not getting better. The fevers are there still or getting worse. You are feeling more fatigued. If you have already been treated with antibiotics or not, and you are getting worse in a few days, I don't know, 3 to 5 days, you've got to see the doctor again, whether it's the Emerge or your GP, depending how sick you are, you'll decide. Because a couple things. Number one, some bacteria are resistant to antibiotics, so you may need a different antibiotic. Number two, it may be a virus, not a bacteria, so you may need other supportive care or treatments. Number three, we may be treating the wrong thing. Maybe this isn't truly a bacterial pneumonia. And there are other kinds of pneumonias like fungal pneumonias, which are more rare. We're not going to get into it. It's a different presentation. There's things like tuberculosis where I practice. It's very, very rampant. So, and then there's other non-infectious diagnoses that could mimic pneumonia. So that is really important. If you're not getting better despite antibiotics, the answer is not usually more antibiotics. It's do more of a workup and figure it out.
Yeah. Like that's where CT scans and things like that come into play. I just want to provide some key statistics. This is my second favorite segment for me. So I just want to point out that this is very common. So the CDC reported that 1.2 million emergency visits in the U.S. with pneumonia as primary diagnosis occurred. So that's quite frequent. And the age is a big risk factor. So older age is a big driver of more severe forms of pneumonia, as Josh had talked about. And hospitalization rates go higher, as the patients have more severe forms. And mortality or death from pneumonia goes up if your age is older as well. So if you're already in the hospital, so you already have severe form of pneumonia, but your age of 18 to 44, your hospital death rate will be much lower. Versus if you're age 65 and above, it approaches something about 10 to 11%. So there's a very, and Josh, I'm sure you see this, patients come in with pneumonia, they're elderly, and not infrequently they could pass away. So I think that's very important. If you're admitted for pneumonia, expect to stay in the hospital. If you're not going to the intensive care unit, for a median of 4 days in the hospital, so that's about roughly patients with run-of-the-mill admissions for pneumonia are. But if you're in the ICU, intensive care unit, it could increase to about 7 days, the rough estimate. So these are some of the
great
fun facts from
point.
Fun Guy.
And common
And
question.
now, James, is there a stat about your daughter not washing their hands with soap, even though they've told you they wash with soap, and the effect that has on pneumonia? You give me that stat,
all of the
please.
time. All of the time.
Well, I mean, I think the most complex generative AI cannot solve that question, Josh.
Yes, no. Only my daughter can. All right, Brodie. Now's your time to shine.
You guys, do you hear that? It's myth busting time.
Yeah,
we really need some theme music here.
Yeah.
All right, Josh. I know there's some myths out here. What do you got for us?
Lots of myths. This is my favorite. You are more likely to get pneumonia or get sick if you are cold or if you don't bundle up when it's cold outside.
I love this.
Completely false. And I meant to look up where that actually came from. I don't know. Now, how I can justify this myth that is false is when it's cold outside, when it's rainy and wet outside, you're spending more time indoors, you're spending more time around people. So you are more likely to get something transmitted from one of them. But this whole, it's -5 degrees Celsius out, I don't know what that is in Fahrenheit, you're more likely to get a cold or pneumonia. This is just not true.
Yeah.
So when your daughter is saying, no, I'm not putting my jacket on before school, I'm not going to tell her you're going to catch a cold. You're going to feel cold.
You're going to feel cold. I say frostbite is real. You can lose a finger, but you won't get pneumonia.
Yeah. So I looked into this a while ago, not related to this, and where I found the origin of that, like you get a cold, you catch a cold from being cold. I think it was more around that people started to feel cold because they were getting rigors and fever just before they got sick. So there's this sensation of, oh, you're feeling cold, like, oh, okay. And that's kind of how you caught a cold, because you're actually referring more to like the rigors and the chills that you get, which then extrapolated out so that you can catch it, so you can catch a temperature. I don't know. That was my dive on it. But either way, myth busted.
Yep.
Love it.
Yeah. I mean, there's a version of this in almost every culture. So we started putting out some socials in Korean subtitles. Every Korean mom uses this to get their children to like bundle up. Myth busted.
All right, who's up? James, you want to give us a myth? And please bust it or confirm it.
Yeah, so this is definitely a fact. So I think it's important for us to get it out there. While we advocate for vaccines for pneumococcal, bacteria, even if you have that vaccine, doesn't mean you're 100% immune to having pneumonia. There are various strains of bacteria and viruses that could lead to pneumonia. So the available vaccines would only cover for the most popular strains of them. So you're not going to be 100% immune from it. But certainly it will cut chances of you getting pneumonia if you get the vaccines, especially if you're over a certain age.
Yep.
Myth busted.
So you're not 100% immune by any means, but you are much more protected than if you don't get it.
There are very few things in life that's 100% guaranteed.
Do you know what's guaranteed, guys? How much fun I'm going to have when I come on this podcast to record with you.
That's right. That's right.
That's very sweet, buddy.
Yes. It's 100%.
Sentimental tonight.
All right, Brodie, you got one?
Yeah, that's hard. I love the cold ones. My favorite. I mean, we touched on this earlier, but pneumonia is not just for old people, right? Again, we see this a lot in younger kids, but also, people that are totally healthy. exercise, eat well, doing all the right things, and you just get exposed to the wrong bug and it can take you down. So again, if you're feeling unwell, again, especially fevers, difficulty breathing, coughing up a bunch of phlegm, and you don't have those other upper respiratory tract symptoms, so again, runny nose, sore throat, then, go get checked out, because it's not just an old and super young people disease. We can all catch the same bacteria.
And I think what's great is this myth pretty much comes up with every diagnosis we talk about.
Yeah.
It's like there's no, medicine used to be ageist. Like, it used to be very ageist, where if you're old, you get these diseases, and it's just not true for the most part. Higher risk, of course.
It's not ageist anymore.
Excellent point. We are trying to be less ageist than we were before.
Yes, yeah, that is true. And I think, even, I think people are living longer. There's a lot of longevity research and practice that are helping people live healthier and longer.
Yep, absolutely. All right, good myth section, guys, as always.
Mm-hmm.
Well done.
Love it.
Takeaway?
Josh, thanks for,
takeaways. Yeah. Pneumonia is frequent. Many people who think they have pneumonia probably don't. They probably have more of this viral upper respiratory tract infection. And true pneumonia needs antibiotics. Most people with symptoms like cough, runny nose, sore throat don't need antibiotics. And I think that's a really, really big takeaway. That have the conversation with your doctor, but please, please, please try to at least believe them when they say you don't need antibiotics. And it's okay to go back a couple of days later and say, hey, I'm really not getting better. Can we rediscuss that?
Yeah.
That's great. I love that.
My take home would be that, so not all pneumonia result in hospital admissions. There's probably more patients who are diagnosed with pneumonia, but end up going home and be treated at home with some antibiotics or supportive therapy. So it all depends on how severe the symptoms are and your underlying medical conditions.
All right. Well, now I'm obliged. Okay. So my take home, I'm going to cover a bit of what Josh had said there too. But if your doctor's saying that you don't need antibiotics, it's not that we're saying that you don't feel shitty and not, acknowledging how awful you feel. We really are trying to save you against those side effects of antibiotics. And again, especially, I would hate that you're already feeling really crummy and now you're having to run to the bathroom with diarrhea for the next 3 days too.
Not all antibiotics cause diarrhea, but frequently it could cause diarrhea.
But frequently,
I just want to point out. Very good. Very good. We should do a diarrhea episode.
Oh, we will. We definitely will.
Yeah.
Guys, super fun. Brodie, congrats on the new home. Can't wait to see you.
Mm-hmm. I guess I'll invite you.
Yes. I have a bedroom in there. James, you do too. He hasn't told you yet, but
we'll get a podcasting studio set up.
We will.
In a closet.
Love it. Have an awesome night.
Thanks,
talk
guys.
to you guys soon.
Good to see you.
We'll see
All
you.
right, take care.